From the humming sterility of Metropolitan General's operating rooms emerges Dr. Julian Vance, a 30-year-old black surgeon whose top honors are matched only by his profound compassion for every life he touches. His dedication is tested when a patient arrives with a catastrophic thoracoabdominal aortic dissection, a case so hopeless every senior colleague had refused, fearing the risk. Julian, however, sees not an impossible statistic, but a chance, leading him to execute a daring, unprecedented surgical maneuver that will not only save a life but irrevocably rewrite the textbooks of modern medicine. If you liked the video and have subscribed to my channel, let's move on to our story. Enjoy watching. The fluorescent lights of Metropolitan General's operating room 3 hummed with a sterile, insistent energy, a familiar, almost comforting counterpoint to the rapid rhythmic beep-beep-beep of the cardiac monitor. Dr. Julian Vance, at 30, was a study in focused intensity. His mocha skin glistened faintly beneath the harsh lights, a stark contrast to the crisp, cerulean surgical scrubs. He had the lean, muscular build of someone who understood that the endurance required for an 8-hour surgery was as much a physical marathon as it was a mental one. His hands, though, were what people noticed most, long-fingered, steady, and possessing a preternatural grace that could tease a thread through the eye of a needle or expertly navigate the treacherous landscape of a human aorta. Julian had graduated first in his class from a medical school where the pressure had been less about academic rigor and more about the expectation to fail. He carried the weight of that success not as a burden, but as a silent, unshakable covenant. Every patient was a testament to the journey, a victory hard won against the odds, both statistical and systemic. He didn't just treat diseases, he treated people. Tonight's patient, a 60-year-old retired carpenter named Arthur Vance, no relation though Julian often joked that all his patients became family in some way, was lying open before him. Arthur needed a complex triple bypass. It was a common procedure, yet in Arthur's case the calcification was severe, turning the familiar soft tissue into something brittle and unforgiving. "Suction please," Julian murmured, his voice low and calm, cutting through the silence of the focused team. His first assistant, Dr. Lena Hayes, a whip-smart, no-nonsense resident, immediately moved the wand into position. "Heart rate stable, Dr. Vance. Pressures holding," the anesthesiologist, Dr. Patel, reported from behind the curtain of monitors. Julian nodded slightly, his eyes never leaving the field. "Good. We are on the left obtuse marginal. Dr. Hayes, retract just a hair more inferiorly, please. I need a clean sight line on the distal anastomosis site." His movements were a dance of precision and speed. The scalpel, the clamps, the fine, curved needles, they were extensions of his will. He could feel the quality of the tissue through the instruments, a tactile intuition that years of study and countless hours in the lab and operating room had honed to an edge sharper than any surgical steel. When Julian tied his sutures, the knots were perfect, miniature sculptures of tension and security, holding a fragile life together with silk-thin thread. He wasn't just performing a technical task, he was in a state of flow, a deep, meditative concentration where time warped and the outside world ceased to exist. In this moment, nothing mattered but the rhythm of the breathing machine, the faint hiss of oxygen, and the beating heart, the organ he held literally and figuratively in his hands. His reputation within Metropolitan General was already legendary, though Julian actively discouraged the fanfare. His peers respected his skill, his residents revered his meticulous teaching, and his patients adored his bedside manner. He possessed a rare empathy. He never looked at an X-ray or a chart first. He always looked the patient in the eye, asked about their life, their family, their fears. He believed the diagnosis was only half the story, understanding the person was the other, crucial half. Healing the body, he often preached, required mending the soul. A week prior, he had spent nearly an hour after a successful gallbladder removal, sitting by the bed of a tearful young mother who had been terrified she wouldn't survive to see her son turn 5. Julian hadn't talked about sutures or laparoscopic techniques. He talked about birthdays, about the resilience of the human spirit, and about the sheer, stubborn audacity of life. His words, delivered with sincere conviction, had done more for her recovery than any pain medication. Arthur Vance's surgery was a success. The new grafts pulsed with life, bright red blood flowing freely. The cardiac monitor settled into a steady, comforting rhythm. "Close," Julian announced, stepping back from the table, allowing the residents to begin the meticulous process of closing the chest. He peeled off his gloves, the snap echoing in the suddenly lighter room. The intensity broke, replaced by a deep, weary satisfaction. "Another day, another victory, Dr. Vance," Dr. Hayes said, her voice filled with admiration as she looked up from the table. Julian smiled, a genuine warm flash of white against his dark skin. "Just another day of keeping the lights on, Dr. Hayes. Make sure Mr. Vance gets a clean post-op angiogram tomorrow morning. I want his heart to sing." The next few days were a blur of routine brilliance. A challenging but standard aortic valve replacement, a few thoracoscopic lung resections, and countless rounds in the intensive care unit, ICU. Julian lived by the schedule, his life structured around the urgent, unpredictable demands of trauma and illness. He slept little, but the work energized him. It was a calling, not a job. One Tuesday morning, as Julian was reviewing charts in his small, brightly lit office, a pall settled over the cardiothoracic surgery wing. The air, usually thick with the sounds of rolling carts and hurried conversations, grew strangely hushed. Julian felt the change before he saw it. It was the specific gravity of dread, a familiar but unwelcome visitor in a hospital. Dr. Eleanor Quinn, the chief of cardiology, a woman known for her icy demeanor and surgical skill that was second only to Julian's, poked her head into his office. Her face, usually a mask of professional control, was etched with fatigue and a subtle, disturbing anxiety. "Julian, I need you in the CT scan review room. Now, drop everything," she said, her voice low and tight. Julian rose instantly, his mind already cycling through worst-case scenarios. A massive tear? A sudden catastrophic aneurysm? He followed her down the hall. The CT review room was already crowded. Several senior surgeons, residents, and the head of trauma, Dr. Malcolm Davies, were clustered around the brightly lit screen. The atmosphere was heavy, a collective holding of breath. Dr. Quinn pointed a laser pointer at the screen. The image was a cross-section of a human torso, but it was unlike anything Julian had seen outside of an advanced pathology textbook. "This is Ethan Miller, 32 years old. Motorcycle accident," Dr. Quinn began, her voice steadying into its professional rhythm. "Multiple rib fractures, pulverized spleen, a small subdural hematoma, all serious but manageable. The problem is here." She circled a pulsating shadow near the center of the image. "He has a massive thoracoabdominal aortic dissection," she stated, the gravity of the words hanging in the room. "The tear began just distal to the left subclavian and runs all the way down into the renal arteries. It's a type A, but with an extension that essentially involves the entire descending aorta." A collective, quiet gasp filled the small room. This wasn't just a tough case, it was a near-mythical beast of pathology. Dr. Davies, the grizzled trauma chief, spoke, his voice gravelly. "He was on the table in the OR within 30 minutes of arrival. We managed the bleeding from the spleen and stabilized the long bone fractures. But we barely touched the chest. We tried to get a balloon pump in, but the sheath tore the intima further down. The aorta is like wet tissue paper." Another surgeon, the usually cocky Dr. Harrison, shook his head slowly. "The false lumen is perfusing his lower extremities. The true lumen is compressed. His kidneys are barely hanging on. His gut perfusion is zero." Dr. Quinn looked around the room, her gaze sweeping over the faces of her colleagues. "We all agree on the immediate plan, a total thoracoabdominal aortic replacement. The procedure requires cross-clamping the aorta for an extended period, which means his spinal cord, kidneys, and gut will be ischemic. The neurological deficit risk is upwards of 50%. The renal failure risk is almost certain. And frankly," she paused, her eyes lingering on the terrifying image, "the risk of the friable aorta tearing apart during the cross-clamping is nearly absolute. Every surgeon on call, Dr. Harrison, Dr. Davies, myself, we have all reviewed the imaging." She let the statement hang, then delivered the cold, hard truth. "We have all refused to operate." The words were a brutal admission of defeat, a surrender to the impossible. These were some of the best surgeons in the country, and they had collectively thrown in the towel. They feared the risk, the almost certain devastating outcome of the surgery and the professional fallout that would accompany the patient's death on their table. They weren't just protecting their records, they were acknowledging the limits of human skill against a catastrophic physiological reality. The room waited. All eyes, cold with resignation, now turned to Julian. They knew why Quinn had brought him here. They knew the whispered legend. Julian Vance never gave up. Julian didn't speak immediately. He stepped closer to the screen, his dark eyes analyzing the image with an intensity that seemed to pull the light toward him. He didn't see the risk profile. He saw a young man, a life 32 years old, teetering on a razor's edge. He saw the potential for a beating heart to stop beating, for a mind to fade, for a family to grieve. He saw Ethan Miller. "His name is Ethan," Julian said softly, his voice cutting through the tension. "What do we know about him?" Dr. Quinn, taken aback by the focus on the patient instead of the pathology, shuffled the chart. "He's a graphic designer. Engaged. Came in stable, then crashed in the ER after the initial chest X-ray showed the mediastinal widening. And what is his current prognosis without intervention?" Julian asked, his voice calm but with an unmistakable edge of steel. Dr. Harrison scoffed, the sound sharp and disrespectful. "Dr. Vance, he's a dead man walking. He'll throw a clot, his kidneys will fail in hours, or the aorta will blow out completely from the pressure differential. He has 6 hours, maybe 8 if we're lucky." Julian turned, facing his colleagues, his posture radiating a quiet authority that belied his age. "So, you are all telling me the collective surgical excellence of Metropolitan General, that a 32-year-old man, a graphic designer, engaged to be married, will die in our hospital because the procedure required to save him is too risky for us to attempt?" He didn't wait for an answer. He moved to the keyboard and began scrolling through the images himself, rotating the three-dimensional reconstruction of Ethan's shattered aorta. He was looking for a window, a single point of leverage, a geological feature in the anatomical nightmare that could provide a foothold. He stopped scrolling. He zoomed in on a segment of the descending aorta, just above the celiac trunk. The false lumen was huge, but the true lumen was not completely obliterated. The tear was deep, but there was a section, perhaps 3 centimeters long, where the outer wall seemed to retain a fractional amount of its integrity, a tenuous bridge between disaster and possibility. "We cannot do a standard clamp and sew," Julian announced, speaking more to himself than to the room. "The minute we cross-clamp, the pressure will shear the outer wall at the clamp site. We lose him on the table instantly." He paced 2 steps, a nervous energy finally manifesting in his otherwise controlled demeanor. He looked at the window, not seeing the bustling city outside, but seeing the impossible architecture of the human body. Then, his eyes widened with a sudden, startling clarity. An idea, reckless, brilliant, and almost certainly career-ending if it failed, blossomed in his mind. "We don't clamp the entire aorta at once," he said, turning back to the room. The other surgeons leaned in, their professional curiosity overriding their dread. "We go in. Stage I, the abdomen," Julian continued, speaking quickly, the plan forming rapidly in his mind, structured and detailed as a surgical protocol. "We access the lower aorta through the flank. We place a small, soft occlusion balloon inside the true lumen, just above the renal arteries, under fluoro guidance. That secures the lower end and buys the kidneys a few hours of grace." "An endovascular occlusion before the open repair?" Dr. Harrison questioned, his voice skeptical. "That's unconventional, Julian." "Unconventional is what saves his life," Julian retorted, his voice sharp. "Stage 2, the chest. Full left thoracotomy. We cannulate the femoral vessels and put him on partial bypass. Then we perform a sequential segmental replacement. We don't cross-clamp the entire affected area. We isolate small, 3 centimeter segments, one after the other. We replace the torn section with the graft, move up 3 centimeters, reclamp, replace, move up again." Dr. Davies whistled softly. "That will take upwards of 18 hours. And every reclamp is a new, massive risk of the vessel wall exploding." Julian met his gaze, his eyes shining with a fierce, almost terrifying determination. "Yes. It will be the longest, most dangerous aortic replacement in this hospital's history. But it distributes the stress. It means the entire force of the patient's blood pressure never hits a single fragile cross-clamp site. It gives us a controlled, repeatable battlefield." He looked directly at Dr. Quinn, the woman who had brought him the impossible patient. "Every one of you refused to operate because the risk of failure was too high. You chose to let a man die of his injury rather than die on your table. I understand the logic. But I didn't become a surgeon to practice safe medicine. I became a surgeon to save lives." He placed both hands on the edge of the viewing desk, leaning slightly into the room. His voice dropped to a level of absolute, unyielding conviction. "I will operate on Ethan Miller. I will use a segmented approach, a combination of open repair and endovascular techniques, to navigate this dissection. He is stable enough now that his only chance is a Hail Mary, and I am the quarterback." A profound silence descended, heavier and more complex than the previous dread. It was the silence of men and women of science confronting an act of pure, audacious courage. Dr. Quinn exhaled slowly, a long, defeated sound. She looked at the screen, then at the unwavering gaze of Dr. Julian Vance. "If you do this, Julian," she said, her voice barely a whisper, "and you fail, the inquiry will be brutal. You will be held personally accountable for pushing the boundaries beyond acceptable standards of care." Julian didn't flinch. "I am already accountable, Dr. Quinn. To the man lying in that bed. Get the OR prepped. I need a vascular surgery consult and 3 cardiothoracic residents for a rotating shift. And I need a lot of blood. Tell Ethan's family that I won't lie to them. This is the most dangerous operation he could possibly undergo. But tell them I am going to make medical history today. Or I am going to die trying to save their son." With that, Dr. Julian Vance turned and walked out of the room, leaving behind a group of world-class surgeons stunned into admiration by the force of his conviction, and the sheer, terrifying complexity of the fight he had just chosen. The fight to save a man whom everyone else had already decided to let go. The clock above the scrub sink in operating room 5 read 1:47 p.m. The usual rhythm of the afternoon had been shattered, replaced by an urgent, focused scramble. Dr. Julian Vance stood at the sink, the hot water running over his hands, performing the surgical scrub with a meditative intensity that blocked out the frantic energy around him. The decision had caused a seismic shift in Metropolitan General. The official paperwork had been brutal. Julian was operating under an extraordinary high-risk waiver, personally signed by the Chief of Staff, Dr. Anya Sharma, who had been pulled from an administrative summit to authorize the medical Hail Mary. The air hummed not just with activity but with witness. Every circulating nurse, every resident, and even the senior surgeons who had declined the case, were now watching either in the gallery or via the closed-circuit feed. This wasn't just a surgery, it was a defining event for the hospital. Julian's team was a carefully curated blend of experience and fortitude. Dr. Lena Hayes, his reliable first assistant, stood beside him, her face grim but resolute. He had also pulled in Dr. Marcus Choi, a veteran vascular surgeon known for his ice-water composure during complex vessel repairs, for the initial endovascular phase. Dr. Patel, the anesthesiologist, had been replaced by a specialist, Dr. Anya Singh, brought in specifically for her expertise in managing the volatile hemodynamics of extensive aortic clamping. "Dr. Hayes," Julian murmured, rinsing his arms. "Run the team brief one more time. Focus on the transition points." Lena spoke clearly, her voice echoing slightly in the tiled room. "Phase 1. Endovascular occlusion. Dr. Choi, you'll place the soft balloon distal to the renal arteries via femoral access under fluoroscopy to secure the lower end and maximize perfusion time for the kidneys. We have a target of 3 hours for kidney protection." Dr. Choi, a man with the weary eyes of someone who had seen too much vascular trauma, nodded. "Balloon is a temporary fix for perfusion, not a long-term clamp. We need to be fast in Phase 2. Phase 2, the segmental repair," Julian interjected, pulling on his sterile gown, Lena tying the back with practiced speed. "Full left thoracotomy. Partial femoral bypass initiated. We'll use a 4 cm Dacron graft for the replacement sections. The critical step, sequential clamping. 3 cm of repair, then release the upper clamp, move it down 3 cm, reclamp, repeat. This means the time the spinal cord is under full ischemia is minimized to small, overlapping segments. We will be using cerebrospinal fluid, CSF, drainage to reduce the risk of spinal cord stroke." He looked at Dr. Singh. "Dr. Singh, the blood pressure management is everything. When the clamp is on, I need that proximal pressure manageable, but when it shifts, I need an immediate, smooth transition. No spikes, no drops. We are sailing a tiny boat in a hurricane." "I hear you, Dr. Vance," Dr. Singh replied, her voice steady. I have 6 units of packed red cells and 4 of fresh frozen plasma cross-matched and ready. I will be using sodium nitroprusside to manage the proximal hypertension and dopamine and norepinephrine to stabilize after the clamp release. This patient's hemodynamics will be my sole focus." Julian took a deep breath. "Then let's go. Time is the enemy." Ethan Miller was draped, a canvas of green fabric shielding the young man's story from the harsh reality of the operating field. Julian paused for a moment, resting his hand lightly on the patient's shoulder, a gesture unseen by anyone but felt by his team. It was a silent acknowledgement of the life they were fighting for. "Incision," Julian commanded. The first phase was swift and technically clean. Dr. Choi, working with his fluoroscopic screen, was a study in efficient, minimal movement. The fine wires and catheters navigated the femoral artery with serpentine grace. Within an hour, the soft, compliant endovascular balloon was in place, successfully isolating the lowest section of the dissection and diverting flow into the true lumen, buying precious time for the renal arteries. "Balloon inflated to 8 atmospheres, Dr. Choi announced. "True lumen pressure restored below the kidneys. Perfusion improved." "Excellent, Dr. Choi," Julian said, his eyes already on the next step. "You've given us a fighting chance." Dr. Choi stepped back and Julian took center stage. The left thoracotomy was a brutal but necessary cut, opening the chest cavity and granting access to the vast, damaged length of the descending aorta. The site of the vessel was harrowing. It was distended, purple in places and pulsating unevenly, the outer wall alarmingly thin and compromised. It looked, as Dr. Davies had noted, like tissue paper. "Cannulate the femoral artery and vein," Julian ordered. Partial bypass was initiated, a circulatory safety net that rerouted a portion of Ethan's blood, easing the load on his struggling heart and providing controlled flow to the lower body while Julian worked on the upper torso. Julian, with a fine-tipped pen, began marking the segments on the exposed aorta, 3 cm increments, meticulously planned to correspond with the least damaged sections of the vessel. He was no longer just a surgeon. He was an architect, planning the reconstruction of a shattered edifice. The first clamp went on, a tiny, specialized clamp placed precisely at the top of the first segment. The team held its breath. Proximal pressure spiking. Dr. Singh warned immediately. "BP is 185/110. Administering S&P. Julian kept his hands rock steady. The clamp had held. The aorta, though, was under immense stress. "Time for first segment cross-clamped. 0, Julian said, his voice measured. "Dr. Hayes, prepare the graft section. Dr. Vance, starting the arteriotomy." He sliced into the diseased segment. The blood flow, though partially managed by the bypass, was still torrentially strong. Julian worked with an almost frantic energy, yet every movement was controlled. He excised the torn, diseased tissue, and the hole left behind seemed catastrophically large. He then began the anastomosis, connecting the new Dacron graft to the patient's remaining healthy vessel. His hands were a blur of motion, the needle passing through the fragile tissue with impossible delicacy. The sutures were placed with the tension of a master weaver, tight enough to seal, loose enough not to tear the fragile wall. 2 minutes and 30 seconds left on the first segment, Lena whispered, her eyes glued to the clock. This was the terrifying reality of the segmental approach. He had to complete a perfect, life-saving repair in less than 5 minutes, or the spinal cord risked irreversible ischemia and paralysis. Julian finished the suture line, tied the final knot, and cut the thread. "Ready to release." "Pressure is normalizing," Dr. Singh reported. Julian ordered the upper clamp released. The tiny segment of graft flushed with blood. Held. "First segment secure," Julian announced, a sliver of relief easing the tension in the room. The process began again. The team reset the clamp, moving it down precisely 3 centimeters. Clamp. Cut. Suture. Release. Hours bled into one another. 4 hours for the upper thoracic aorta. 6 hours for the mid-chest section, where the dissection was at its most volatile. Julian did not allow himself to blink more than necessary. He consumed electrolyte drinks through a straw held by a circulating nurse, his focus unwavering. The team rotated residents, but Julian, Lena, and Dr. Singh remained constants, their endurance fueled by caffeine and pure, adrenaline-laced determination. Around the 10-hour mark, the weariness became a physical entity in the room. Dr. Singh's voice was hoarse as she continued to dictate the volatile blood pressure numbers. Lena's hands moved with professional competence, but her body language betrayed her exhaustion. Julian, however, seemed to enter a deeper state of focus. The initial apprehension was gone, replaced by a quiet fury against the disease. He spoke less, relying on the unspoken understanding with his team, communicating through the precise placement of his instruments and the silent expectation in his posture. He was now nearing the abdominal section, the point where the lower thoracic and upper abdominal aorta met, a region densely packed with crucial arteries feeding the gut and liver. Approaching the celiac and superior mesenteric arteries, Julian stated. This next anastomosis must be perfect. If we compromise the mesenteric flow, we lose the bowel. He took a slow, deep breath, adjusting the headlamp. This required a level of meticulousness that bordered on the superhuman. The vessel walls were almost transparently thin here. As he was placing the needle for the anchor stitch of the 9th segment, the cardiac monitor let out a long, piercing wail. Ventricular fibrillation. Patient is crashing. Dr. Singh shouted. We've lost his rhythm. Julian's hands froze, the needle suspended mid-air above the patient's open chest. His mind raced, calculating the catastrophic possibilities. The segmental clamp was on, isolating the section. The partial bypass was running. Why VFib now? Paddles? Dr. Singh yelled. Charging to 200 joules. No. Wait. Julian's voice cracked through the panic in the room, sharp and authoritative. Dr. Singh checked the bypass flow. We might have air embolism or a cannula occlusion. Dr. Singh, a veteran, instantly understood the implication. The last thing they needed was a shock to an already fragile aorta. She checked the line. Flow is clear. Wait. The blood return temperature is dropping rapidly. The heart is chilling. Hypothermia-induced VFib, Julian deduced instantly. The sheer length of the open chest surgery, combined with the volume of blood passing through the bypass circuit, had dropped the core temperature too low. Increase the perfusate temperature. Maximize the blanket temperature. We are going back to sinus rhythm with heat, not electricity. Julian commanded, his eyes still on the suture line. Dr. Hayes, hold pressure on the segment. Do not allow the clamp to shift. Singh, you have 30 seconds to get that core temperature up. The team worked in a coordinated frenzy. Julian, trusting his anesthetist completely, didn't move. He kept his hands in position, preserving the delicate repair work. 30 seconds stretched into an eternity. Then the long, flatline alarm broke, replaced by a stuttering, irregular rhythm, and finally, a fragile, slow beep-beep that signaled a return to sinus rhythm. Sinus rhythm restored, Dr. Singh announced, her voice shaky with relief. Temperature rising. That was too close. Julian let out a silent exhale, his focus never leaving the microscopic task. It was close enough. Let's finish this segment. 2 more to go. After 12 long hours, he placed the final suture for the penultimate segment. The replacement graft ran from just below the subclavian artery all the way past the major abdominal vessels. A glorious, continuous pipeline of synthetic material seamlessly connected to the patient's own anatomy. Finally, he ordered the balloon and all remaining clamps removed. Blood flow rushed into the repaired aorta, testing the integrity of 12 hours of impossible work. The monitor held steady. The pressure stabilized. The graft pulsed with life. Julian stepped back, the world spinning slightly as the adrenaline receded. The room was silent, save for the mechanical sounds of the monitors and the faint, steady drumming of Ethan Miller's own heart. He had done it. He had faced down the consensus of surgical science, stared into the abyss of failure, and with an audacious, segmented approach, he had stitched an almost completely destroyed aorta back into life. Close him up, Julian whispered, peeling off his blood-soaked gloves, the exhaustion finally hitting him like a physical blow. He looked down at the patient, not a young graphic designer, but a man given a second chance, healed by a blend of courage, compassion, and a surgical skill that had pushed the boundaries of medical history. He looked up at the clock, 3:05 a.m. The longest night of his career was over, and a life, once forfeited, was now secured. The exhaustion that hit Dr. Julian Vance upon leaving operating room 5 was absolute. It was a physical, bone-deep weariness that settled into his muscles and fogged the sharp edges of his mind. He spent 15 minutes in the recovery room, observing Ethan Miller. The patient's vital signs were tenuous but stable, a triumph in itself. The new synthetic aorta was performing its duty flawlessly, a ribbon of hope now pulsating where a ticking time bomb had been just hours before. The greatest immediate danger, the complete aortic rupture, had been averted. "Dr. Hayes," Julian murmured, his voice gritty, leaning against the doorframe. "Monitor his urine output religiously. We averted full ischemia during the clamping, but the kidneys are still stressed. We need 50/text cc per hour. If it drops, initiate dialysis protocol immediately. Also keep the CSF drain open. The spinal cord is our next major concern." Dr. Lena Hayes, her own face pale with fatigue, nodded crisply. "Understood, Dr. Vance. I've alerted nephrology and neurology. They're on standby. Dr. Miller is a priority one for the next 48 hours. Julian simply nodded. He knew the next few days were just as crucial as the surgery itself. A successful reconstruction meant nothing if the patient succumbed to multi-organ failure or a neurological event in recovery. The battle was won, but the war for Ethan Miller's life had just begun. He finally stumbled out of the ICU and into the harsh fluorescent light of the hospital corridor. It was 4 a.m. He needed a shower, food, and at least 4 hours of oblivion, but his path was immediately blocked. A phalanx of people stood waiting. In the front were Mr. and Mrs. Miller, Ethan's parents, their faces etched with the agonizing sleeplessness of the last 17 hours, and Sarah, Ethan's fiancée, whose eyes were wide and red-rimmed. Behind them, standing stiffly, was Dr. Anya Sharma, the chief of staff, and 2 members of the hospital's risk management board. Julian instinctively straightened, pushing the fatigue back. He walked directly to the Millers. "Mr. and Mrs. Miller, Sarah," he said, his voice quiet but steady. "The surgery is complete. It was long, and it was the most difficult procedure I have ever performed." He did not use jargon or minimize the risk. He spoke plainly, honoring their terror. "Ethan's entire descending and thoracoabdominal aorta has been successfully replaced. The graft is holding. His heart is strong. We faced major complications, including a temporary cardiac event on the table, which we resolved. He is alive and he is stable, but he is in critical condition. The next 72 hours will be a tightrope walk. We are watching his kidneys and his neurological function closely. But I promise you he has the best care in this facility, and he has fought like a lion." Mrs. Miller gasped, clutching Sarah's hand, tears finally spilling over in an overwhelming mixture of relief and continuing fear. "Thank you, doctor. Oh God, thank you." Julian squeezed Mr. Miller's shoulder. "I'll see him again in 2 hours. You rest now, go to the waiting room. I will update you as soon as there is any change." As the family was gently ushered away, Dr. Sharma stepped forward. Her expression was complex, a mixture of professional relief and administrative coldness. "Julian," she began, her voice low. "Remarkable work. Truly historic. You've saved a life that every other surgeon, myself included, was prepared to mark as a non-starter. However, we have a formality to deal with." She gestured to the 2 men in tailored suits behind her, the risk management team. Their presence, even at this hour, was a clear statement. His success was not yet fully sanctioned. "We need a full debriefing on the surgical protocol you executed," the lead manager, Mr. Trevor Sloan, stated, his tone devoid of emotion. "Specifically, the deviation from standard type A-B aortic repair, the sequential segmental approach with preemptive endovascular balloon occlusion. We need to document why the accepted standard of care, SOC, was bypassed." Julian stared at them. After 16 hours in the trenches, this bureaucratic dissection was infuriating, but he knew the game. The SOC was bypassed because the SOC would have guaranteed the patient's death, Julian stated, his eyes fixed on Sloan. The friability of the aortic wall, as documented on the pre-op CT scans, made a standard cross-clamp procedure impossible. The single, full cross-clamp would have resulted in an immediate, catastrophic tear and bleed out. He leaned against the wall, crossing his arms. "My approach was tailored to the pathology. The endovascular balloon stabilized the distal perfusion to protect the kidneys before the main event. The sequential segmental clamping distributed the shear stress across multiple brief intervals, preventing the catastrophic wall rupture. It mitigated the primary risk, death on the table, in favor of manageable postoperative risks like kidney or neurological issues, which we are now addressing. Dr. Sharma intervened smoothly. Mr. Sloan, Dr. Vance's reasoning is sound and is now demonstrably correct by the patient's survival. However, the use of partial bypass combined with a segmented, multi-hour replacement is an innovation. It must be codified. Sloan scribbled on his pad. And the VFib incident at the 10-hour mark? Your decision not to immediately defibrillate and instead rely on thermal stabilization. Explain the rationale for that risk. Julian felt a fresh wave of irritation. The patient had a localized clamp in place. Defibrillation would have delivered massive electrical energy across a partially open chest and a newly placed, fragile anastomosis. The mechanical stress alone could have ruptured the repair, leading to instant, fatal hemorrhage. Dr. Singh recognized a temperature drop. It was a hypothermia-induced event. The safer, non-mechanical solution was rapid rewarming of the blood, which successfully restored rhythm without compromising the surgery. He paused, letting his gaze convey the absolute confidence of his judgment. I was following the Hippocratic Oath, primum non nocere, first do no harm. In that moment, defibrillation was the greatest harm. The administrative questioning continued for another hour, a sterile, legalistic interrogation designed to protect the hospital's assets in the event of an eventual complication. They pressed him on the long-term viability of the segmented repair and the expected quality of life for Ethan Miller. Julian answered with the precision of a scientist and the conviction of a crusader. He detailed every metric, every drug, every minute of the monumental operation. Finally, the suits departed. Dr. Sharma remained, watching Julian with an intensity he rarely saw in her eyes. Julian, she said, resting a hand on his arm. Your decision was an act of pure professional courage. You stood against 5 senior surgeons and you were right. You have not just saved a life, you've potentially written a new chapter in aortic surgery textbooks. She leaned in, her voice dropping to a conspiratorial whisper. The other surgeons, the ones who refused the case? They're now spinning this to the board. They are simultaneously amazed and terrified. Terrified because your success highlights their calculated inaction. They are calling it reckless brilliance. Julian simply looked down the hall toward the ICU, seeing the light over Ethan's room. I don't care what they call it, Dr. Sharma. It was necessary. Reckless is letting a 32-year-old man die in the trauma bay because the treatment is difficult. Sharma smiled faintly, a rare, genuine expression of respect. The hospital will support you. The press is already calling. The initial news is going to be immense. You're no longer just a top surgeon, Julian. You are a medical hero. Prepare yourself for the spotlight. I just want Ethan to wake up, Julian said, the exhaustion finally pulling him down. Go home, doctor, Sharma insisted. Go home and sleep. I'll take the 7 a.m. update with the family. You've earned the rest of the day. He was too weary to argue. He nodded, thanked her, and headed toward the elevator. As he descended, his phone buzzed. It was a text from Lena Hayes. Urine output steady at 65\text, cc/hr. Neuro check. Wiggle toes positive. We're fighting. Julian closed his eyes, a small, weary smile crossing his lips. Wiggle toes. 2 simple words that meant the spinal cord had survived the segmental clamping. 2 words that meant he hadn't just saved Ethan Miller's life, he had saved his future. The spotlight and the scrutiny could wait. The victory was in the quiet, profound miracle of a man being able to wiggle his toes after the impossible had been achieved. Julian woke abruptly, disoriented by the silence. He was in his small, minimalist apartment near the hospital, the curtains drawn, casting the room in a cool twilight. His body protested every movement, a symphony of aches after 16 hours of standing and focusing. He checked his watch, 11:30 a.m. He had managed 7 hours of the most profound sleep of his life. He immediately grabbed his phone. 5 missed calls from Dr. Sharma, dozens of texts, and a flurry of emails. He bypassed them all, going straight to the message thread with Dr. Lena Hayes. The latest text, time-stamped 11:15 a.m., was the only one that mattered. Stable. Vitals excellent. Wiggled toes and fingers on command. Patient awake and asking for water. He remembers the motorcycle. Neurosurg is ecstatic. "We're moving mountains, Dr. Vance." A long, slow wave of relief washed over Julian. The neurological integrity was the greatest immediate victory. The segmental clamping, his reckless, brilliant gamble, had paid off. The spinal cord was intact, the risk of paraplegia averted. Ethan Miller hadn't just survived. He had retained his self. Julian called Dr. Sharma first. "Julian, thank God you're up." Her voice was an urgent whisper. "Ethan is officially out of immediate danger. The urine output UO is solid, no sign of acute tubular necrosis. His blood gases are great. It's a miracle, Julian. A textbook-defying, career-making miracle." "And the rest of the hospital?" Julian asked, already knowing the answer. "It's a circus. Dr. Harrison and Dr. Davies are now claiming they paved the way by diagnosing the impossibility of the standard approach. The press is downstairs trying to breach security. The New York Times called, wanting an exclusive on the sequential aortic replacement technique. And the dean of the medical school is here. He wants to talk research grants and tenure track." "Tell the dean I'll speak to him after I see my patient," Julian said firmly. "And tell the press nothing until I've cleared it with the Millers. We need to focus on his recovery first." Julian arrived at Metropolitan General and found the security tightened. He bypassed the throng of reporters camped near the main entrance, taking a subterranean route directly to the cardiothoracic ICU. He found Ethan Miller's room, the quiet room, a beacon of hushed intensity. Ethan was still intubated, the breathing tube a necessity for his recovering lungs, but his eyes were open, lucid, and following the movements of the nurse. Sarah, his fiancée, sat by his bedside, holding his hand, tears streaming down her face, not of sorrow but of profound gratitude. Lena Hayes was standing near the monitor, her face radiating the exhaustion of the vigil mixed with the elation of success. Julian went to Ethan's bedside. He leaned down, placing a hand gently on Ethan's forehead. "Ethan, it's Dr. Vance. You did it, son. You survived the impossible." Ethan's eyes flickered to Julian's face. He tried to speak but the tube prevented it. Sarah quickly handed Julian a small whiteboard. Ethan's hand, though weak, picked up the marker and scrawled two large, shaky words, "Thank you." Below that, he added a simple question, "Paralyzed?" Julian smiled, a genuine, heartfelt expression that eased the worry in the room. "No, Ethan. You are not paralyzed. You have full motor function. Your spine is safe. You're going to walk out of here. But first," he tapped the tube, "you need to breathe on your own." He turned to Sarah. "He's through the worst of it. The next few days are for weaning him off the ventilator and managing his pain. He's a fighter, Sarah. And he knows he's loved. That's half the recovery." Julian spent the next hour reviewing the charts, his mind snapping back into diagnostic mode. The post-operative markers were phenomenal. The new technique had minimized the systemic shock typically associated with such extensive aortic surgery. Leaving the ICU, Julian was intercepted by the dean, a portly, silver-haired man named Dr. Robert Sterling, flanked by a representative from the National Institutes of Health, NIH. They led him into a private conference room, far from the chaotic corridor. "Julian," the dean boomed, shaking his hand with an enthusiasm that felt performative. "What you've done is monumental. We are calling it the Vance Segmental Technique." The NIH representative, a stern woman named Dr. Alana Reed, cut to the chase. "Dr. Vance, the NIH is prepared to fast-track a $5 million grant for a multi-center study. We need to prove this technique is reproducible. Your success is an anomaly right now, a heroic one but an anomaly nonetheless. We want to fund the protocol development, the specialized clamping tools, and the training of a new generation of surgeons." This was the reward, not just acclaim but the chance to turn a single act of courage into a standard of excellence that could save thousands more. "I accept," Julian said without hesitation. "But the grant must focus on patients previously deemed inoperable. I won't use it to turn routine aortic cases into massive procedures." "Agreed," Dr. Reed said, impressed by his ethical clarity. "The focus is on the impossible patient." Then the dean brought up the second, more personal aspect. "Julian, you're 30 years old. You are on track for a career that rivals the pioneers. Metropolitan General wants to secure your future. We are offering you a tenured professorship and the chief of aortic surgery position, effective immediately. Full control over your time research budget and staffing. You can write your own ticket. This was the pinnacle, the fulfillment of every exhaustive study session and sleepless night. But Julian paused. He remembered the cold calculation in the eyes of the surgeons who had walked away from Ethan Miller. He remembered the initial dismissal of the risk management team. "Dean Sterling," Julian said, his eyes level. "I appreciate the offer. I will accept the professorship and the chief position, but it comes with a condition." The dean leaned forward, suddenly cautious. "The patient Ethan Miller was abandoned by the established consensus," Julian stated. "My success was not just technical, it was a matter of professional and ethical will. I want to establish a center for high-risk and humanitarian surgery within Metropolitan General, fully funded by the NIH grant." He laid out his vision. "This center will accept patients refused by 3 or more surgeons at major institutions. It will be a magnet for the cases everyone else considers hopeless. It will be a place where we prioritize the patient's life over the surgeon's liability profile." He looked directly at Dr. Reed and Dean Sterling. "If you want the Vance technique, you have to take the Vance ethic. I will lead the research, the training, and the surgery, but only if that center is established." The dean hesitated for a long moment, weighing the administrative headache of a dedicated high-risk unit against the immense prestige Julian Vance now commanded. The calculus was simple. "Done," Dean Sterling agreed, his smile returning, wider and more genuine this time. "The Vance Center for Humanitarian Surgery. We'll start the paperwork today." As Julian stood to leave, the door opened and Dr. Harrison, the senior surgeon who had scoffed at Julian's plan, walked in. He looked tired, humbled, and deeply serious. "Julian," Harrison said, his voice stripped of its usual arrogance, "I'm not here for the press conference. I'm here to apologize. I looked at the images and saw only the risk. You looked at the images and saw the possibility of life. What you did was an inspiration. You made medical history today not through technology but through courage." Julian simply nodded, accepting the apology without gloating. "Thank you, Dr. Harrison. The center is going to need the best hands in this hospital. We all have a lot more to learn." He had saved Ethan Miller's life, secured his research future, and gained the respect of his harshest critics. He walked out of the conference room and headed back to the quiet room, to the one person who truly understood the gravity of what had been achieved. He was no longer just a doctor. He was the architect of the impossible, and the rising tide of his fame was about to lift Metropolitan General onto the global stage. The days following Ethan Miller's surgery dissolved into a blur of clinical care, administrative reorganization, and unprecedented media exposure. Dr. Julian Vance found himself not just managing a patient in the ICU, but managing a global narrative. Ethan Miller's recovery became the central, thrilling headline across medical and mainstream news outlets. The Vance segmental technique was lauded as a breakthrough, a daring combination of endovascular and open-heart surgery that offered a new lease on life for the seemingly inoperable. News reports featured striking 3D reconstructions of the rebuilt aorta, juxtaposed with Julian's calm, compelling face. Julian handled the sudden fame with characteristic grace and a clear sense of purpose. He gave limited interviews, always steering the conversation away from personal heroism and toward the creation of his new initiative, establishing the Vance Center. Within 72 hours of the surgery's successful completion, the Vance Center for High-Risk and Humanitarian Surgery was officially greenlit. Julian's condition for accepting the professorship was now the centerpiece of Metropolitan General's strategic plan. He immediately designated Dr. Lena Hayes as his associate director, recognizing her commitment and stellar performance during the grueling operation. They converted a section of the hospital's underutilized research wing into the center's administrative and preparatory unit. "We need a different kind of ethos here, Lena," Julian told her, sketching out the organizational chart on a whiteboard. "This isn't just a place for impossible surgeries, it's a place for impossible hope. Our mantra is simple: we take the patient, not the pathology." The center's first priority was establishing the intake protocol. True to Julian's promise, they implemented a strict rule. Only patients who had been formally refused surgery by at least 3 other major cardiac or vascular centers would be accepted. This guaranteed that the center focused its finite resources on those truly without options. The NIH funding already flowing in was earmarked for 2 things: specialized equipment, including advanced intraoperative neuromonitoring devices to better manage spinal cord protection, and building a dedicated rotating surgical team trained specifically in the segmental technique. Julian also mandated a revolutionary approach to patient communication. Every case, no matter how dire, would be discussed with the patient and family using the same courageous candor he'd shown the Millers. No false hope, but a full, clear explanation of the surgical risks, balanced against the certainty of death without intervention. The first referral. The global media attention meant that applications poured in immediately, hundreds of electronic medical records (EMRs) from every continent, chronicling stories of chronic pain, rare tumors, and conditions that had baffled and defeated conventional medicine. Julian, however, didn't have to wait long for the center's first official, highly scrutinized referral. It arrived via a secured email from the Mayo Clinic. The case was that of Elias Thorne, a 45-year-old former firefighter from Arizona. Elias suffered from a rare, massive pseudoaneurysm of the pulmonary artery, a ballooning sac of blood outside the vessel wall, located deep within his chest. The pathology was unique and terrifying. The pseudoaneurysm was adhering to his trachea and his superior vena cava, SVC, the main vein bringing blood to the heart. Every attempt to surgically access or repair it would likely result in one of two catastrophic outcomes. If they touched the trachea, he would bleed out. If they manipulated the SVC, he risked a complete collapse of venous return to his heart, causing immediate cardiac arrest. The consulting surgeons at Mayo had determined the mass was currently stable, but would eventually rupture, killing Elias instantly. Their conclusion was unanimous. The surgical risk of catastrophic hemorrhage and guaranteed death on the table was near 100%. He had been given 6 months to live. 3 major surgical teams had formally refused the case. Julian sat in his new office, the sun streaming onto the polished mahogany desk, his focus narrowed solely on Elias Thorne's CT scans. The image on the screen was a stark diagram of impossible geometry. "It's like a grenade resting against 2 crucial tripwires," Julian mused to Lena, who was reviewing the scans beside him. "It is," Lena confirmed, running her finger over the screen. "And it's huge. It's compressing his left mainstem bronchus. He's already struggling to breathe. We can't use our standard approach. A sternotomy would give us access, but the moment we try to retract for exposure, we risk rupturing the SVC adhesion." Julian leaned back, a familiar look of intense concentration settling over him. This was exactly why the center existed. Not to do difficult surgery, but to invent new surgery. "We need to go around it," Julian said slowly, the idea beginning to form. "We can't approach from the front. We need a different angle. A hemisternotomy combined with a targeted lateral thoracotomy. A keyhole approach giving us 2 lines of access, one for controlled circulation management and one for the actual dissection." He stood up and walked to the wall, where a large 3D anatomical model of the thoracic cavity hung. He pointed to the exact location of the pseudoaneurysm. "We will cannulate the patient for full cardiopulmonary bypass (CPB) via the groin, placing him on life support before we even touch the chest. This gives us full control over his SVC and pulmonary circulation. Then we use the lateral approach to slowly, meticulously dissect the aneurysm off the trachea using microtools and a high-power microscope. The final step, we use the limited hemisternotomy access for the actual suture repair of the pulmonary artery." Lena's brow furrowed. "That dissection will take hours, Dr. Vance. The risk of air embolism or uncontrolled bleeding from the SVC adherence is immense," Julian finished for her. "But the alternative is certain death in 6 months. We eliminate the risk of the SVC rupture causing immediate collapse by placing him on full bypass before opening. We take the SVC out of the equation. We control the environment, then we fight the pathology." He looked at Lena, his eyes alight with the fierce courage that had saved Ethan Miller. "This is our second chance to prove the Vance Center is necessary. Elias Thorne deserves the same audacity Ethan Miller received." The decision was made. The center's first official high-stakes humanitarian case was on the schedule. Julian walked toward the door, already planning the preoperative imaging protocol. He was ready to face the world's most terrifying patient once more, and this time the world was watching with bated breath, eager to see if the young doctor's historical success was repeatable, or merely a fluke of genius. The preparations for Elias Thorne's surgery transformed the Vance Center into a laboratory of focused urgency. Julian had dubbed the procedure the keyhole dissection and bypass, a two-front war against a single catastrophic pathology. The tension was higher than it had been for Ethan Miller, primarily because the potential for immediate, unsalvageable complications was exponentially greater. Julian insisted on an unprecedented level of preparation. For 3 days, the surgical team, comprising Dr. Lena Hayes, a specialized cardiac anesthesiologist, and an expert in CPB, cardiopulmonary bypass, ran through the procedure using a high-fidelity simulator. They practiced the transition to full bypass, the meticulous, almost microscopic dissection near the trachea, and the contingency plans for every possible tear in the SVC or pulmonary artery. Every movement was timed, measured, and repeated until it became muscle memory. The day of the two-front war. The operating room was vast and intimidating, filled with equipment for both open-heart and endoscopic surgery. Elias Thorne was gently placed on the table. He was weak but lucid, and Julian had spent 20 minutes with him before the pre-op medications, discussing his wife, his 2 daughters, and his profound, quiet acceptance of the terrifying odds. "We are going to fight for you, Elias," Julian had promised, shaking his hand. "I know, doctor," Elias had replied, his voice raspy from the tracheal compression. "Just make it count." Julian's initial move was a declaration of total control. "Dr. Hayes, begin cannulation for full CPB." The team swiftly placed the cannulae in Elias's groin vessels. Within an hour, Julian made the command, "Initiate full bypass." Elias's circulation was now completely controlled by the heart-lung machine. The surgeons had deliberately taken over his life support to mitigate the primary risk. The SVC, the vein adhered to the aneurysm, was now functionally bypassed, reducing the catastrophic consequences if it were torn. "Vitals stable on full bypass," the perfusionist reported. "Flow at 5.0 /text, L/min. Julian nodded, his eyes fixed on the chest. First incision. Lateral thoracotomy. He performed a precise incision on the side of Elias's chest, creating the keyhole access point. This was the window for the microscopic dissection. The view was limited, requiring the use of specialized, long-handled instruments and a high-definition endoscopic camera. Second incision. Hemisternotomy. Minimal opening, Dr. Hayes. We need just enough space for the pulmonary artery repair later. The setup was complete. A lateral access point for the deep, dangerous work, and a front access point for the final repair, all while the patient was fully dependent on the machine. The dissection, a knife-edge battle. The deep dissection phase began, and the room fell into a heavy, concentrated silence. Julian was working through the narrow thoracotomy, using the endoscope to navigate the dark, cavernous space. The massive pseudoaneurysm was exactly where the CT had shown it, a dark, pulsating mass glued to the fragile wall of the trachea and fused to the superior vena cava. Magnification up to 10 \text. Julian ordered, his face pressed close to the endoscopic monitor. He began the slow, torturous process of separating the aneurysm from the surrounding vital structures. The adhesions were tough and fibrous, a result of chronic inflammation. He used an ultrasonic scalpel, which cuts and cauterizes simultaneously, moving with the precision of a watchmaker. "Adhesion to the trachea," Julian murmured, his voice a low hum of focus. 1 millimeter at a time. Dr. Hayes used the suction microwand. "I need a dry field immediately behind my instrument." Hours crawled by. The constant rhythmic hiss of the CPB machine was the only sound besides Julian's occasional clipped commands. Every second movement carried the risk of the instrument slipping, puncturing the pseudoaneurysm, or worse, tearing the trachea. A tracheal tear this deep, with the patient on full bypass, would be an almost impossible hemorrhage to control. At the 4-hour mark, Julian hit a wall of dense, scar-like tissue that formed the main adherence to the SVC. "This is the core," he announced. "It's fused. If we pull, the SVC will tear wide open." He paused, resting his hands on the patient's chest for a moment of reset. He called for a specific, fine-tipped microdissector, a tool usually reserved for neurosurgery. "We cannot pull. We must shear," Julian decided. "I am going to work the tissue from the aneurysm side, shaving off the outer layer until I am just microns from the SVC wall." This was pure audacity. He was deliberately coming close to the pseudoaneurysm wall, risking rupture to save the SVC. For the next hour, Julian worked in this narrow, terrifying space, his breathing shallow, his focus absolute. He was in the zone again, where the world shrunk down to the tip of his instrument and the beating pulse of the machine beside him. Finally, with a soft, tearing sound that echoed unnervingly through the microphone, the last fibers of the SVC adhesion snapped free. SVC clear, Julian announced, a wave of palpable relief passing over the team. The repair. The next phase involved excising the aneurysm. Julian secured the pulmonary artery both proximally and distally, isolating the monstrous, pulsing sac. He swiftly removed the pseudoaneurysm, and the space it left behind was vast, confirming the immense pressure it had been exerting. Now came the final, delicate stage, repairing the underlying defect in the pulmonary artery using the hemisternotomy access. Working through the limited opening, Julian began the repair. The vessel wall, weakened by years of stress, needed reinforcement. He used a piece of Dacron patch, stitching it meticulously over the defect with double-armed sutures, creating a strong, secure repair. After 6 hours of high-wire surgery, Julian finally stepped back. Turn off bypass. Wean him off CPB. The team worked to slowly restore Elias's own circulation. The heart, briefly resting, took over. The graft held. The pulmonary artery pulsed with clean, strong flow. We have excellent native circulation, the perfusionist confirmed. Pressure stable. No leaks. Julian ordered the incisions closed. As he stripped off his gloves, the exhaustion was staggering, but his eyes were shining. He hadn't just separated the components of a ticking bomb. He had disarmed it and rebuilt the internal wiring. Elias Thorne is off bypass, Julian announced to the team, his voice ringing with hard-won victory. He is intact. The trachea is safe. The SVC is safe. The repair is holding. Another impossible patient saved. Julian had faced the impossible twice, under the full scrutiny of the world's medical community, and twice he had redefined the possible. The Vance Center was not just an idea, it was a proven powerhouse of surgical courage. He knew now the administrative battle would be easier. The results spoke a language that even the most cynical committee could not ignore. The success of Elias Thorne's surgery secured Dr. Julian Vance's reputation not just as a brilliant surgeon, but as a genuine innovator. The Vance Center for High-Risk and Humanitarian Surgery transitioned from a promising initiative to a globally recognized surgical mecca. Referrals for impossible cases flooded in, forcing Julian and Dr. Hayes to build a highly selective, specialized team capable of enduring the prolonged physical and mental stress of continuous, boundary-pushing operations. Julian's life became a demanding equilibrium of clinical duty, research, and ethics. He was teaching the segmental technique, applying for patents on specialized microtools developed for the keyhole dissection, and constantly defending the center's high-risk profile to the ever-present scrutiny of the hospital board. The center's ethos. The atmosphere within the center was unlike the rest of Metropolitan General. It was a place of quiet focus and deep empathy. Julian instilled a culture where failure was not professionally devastating, provided every decision was ethically sound and rigorously documented. He understood that pushing the boundaries meant accepting a higher rate of complication, but he offset this with the highest commitment to care, spending hours at the bedside of both his successes and his few heartbreaking failures. One afternoon, Julian was reviewing the EMR of a potential patient, a child with a massive congenital tumor near the heart, when Dr. Hayes walked in, her face drawn. "Dr. Vance, I need to talk about Mr. Ramirez," she said, referring to a patient on whom Julian had operated 3 weeks prior. Mr. Ramirez had suffered a complete aortic arch collapse following a near-fatal infection, a procedure Julian had managed with an ingenious, customized graft replacement. The surgery was a technical triumph. Julian looked up immediately. His vitals were excellent this morning. Full ambulation. What's wrong? He crashed 10 minutes ago. Massive pulmonary embolism. They're running a code now, Lena said, her voice tight with contained distress. Dr. Singh and the ICU team are doing everything. It's not a surgical complication, Julian. It's a systemic failure. The infection caused deep venous thrombosis that broke free. Julian felt a familiar, sickening drop in his stomach. The fight to save a life never ended at the suture line. He rushed down to the ICU. The scene in Mr. Ramirez's room was chaos contained. The team worked with disciplined intensity, administering thrombolytics and attempting to restore rhythm. Julian stood back, watching, his expertise making the awful diagnosis. The clot was too large, the event too sudden. After 20 minutes, the code was called. The price of success. Julian performed the devastating ritual of informing Mr. Ramirez's wife. He did not hide behind medical jargon. He explained the event, a failure of his body's own system, unrelated to the surgery but a tragedy nonetheless. He stayed with her until her pastor arrived, absorbing the waves of grief, understanding that his compassion was as vital as his scalpel. Later that evening, exhausted and emotionally drained, Julian was cornered by Dr. Harrison near the surgical scheduling board. "I heard about Ramirez," Harrison said, his tone surprisingly gentle. "It was an incredible save, Julian. But you know this is the price. The patients you take on are so compromised, even perfect surgery doesn't guarantee a clean recovery." "He was walking out of here next week, Harrison," Julian countered, his voice raw. "He was fine." "He was stable," Harrison corrected, looking Julian directly in the eye. "And that's different. Look, I'm not saying this to tear you down. I'm saying it because you have to learn to absorb the loss. You're carrying the emotional weight of every life that walks through your center." Harrison placed a hand on his shoulder. "The rest of us who practice conventional surgery get to have a 95% success rate. You're building your career on the other 5%. Those wins feel like magic, but the losses will feel like a punch to the soul. You can't let this break you, Julian. The center needs your focus." Julian understood the warning. His surgical courage was based on a radical empathy that forced him to fully invest in every patient's outcome. But he realized that the more impossible the surgery, the closer the shadow of mortality walked beside him. His success with Ethan Miller and Elias Thorne had created an illusion of invincibility, but Mr. Ramirez's death was a stark, brutal reminder of the limits of even the most heroic medicine. The ethics of the impossible. The loss reframed Julian's approach to the next major referral. Sophia Elms, a 50-year-old music teacher with a massive retroperitoneal sarcoma, a malignant tumor wrapped around the patient's entire abdominal aorta and vena cava. Oncologists had deemed it inoperable. Removing the tumor meant excising, replacing, and rebuilding the two largest vessels in the human torso, an undertaking considered a death sentence due to blood loss and visceral ischemia. Julian met with Sophia. She wasn't fearful, she was fiercely determined. "Dr. Vance, I've listened to the other doctors. They told me to go home and get my affairs in order. But I'm not ready to stop teaching my students," she said, her voice steady. "I know the risks. I know the surgery is considered impossible. But I also know you're the only one who doesn't see a dead woman on the table. You see a chance." Julian, chastened by the recent loss, spoke with a sober, unflinching clarity. "Ms. Elms, the probability of dying on the table due to uncontrolled hemorrhage is above 50%. If you survive, the chance of losing kidney function or suffering bowel necrosis is extremely high. You may survive the tumor removal only to face a lifetime of dialysis and severe dietary restrictions." "And without it?" she asked. 6 months maximum. "Painful, debilitating, and certain," Julian replied. Sophia smiled faintly. "Then the choice is simple. A chance to live, however difficult, is better than a guarantee of dying. I trust your courage, doctor." Julian left that consultation with a renewed sense of purpose. The ethical imperative was clear. As long as the patient understood the true costs, he was obligated to fight for them. Mr. Ramirez's death had taught him a painful lesson about vulnerability, but Sophia Elms had reinforced the core value of the center, giving voice to the desperate, last request for a chance at life. He knew this surgery, rebuilding the great vessels of the abdomen while fighting a massive tumor, would require a new level of innovation, combining the segmental technique with radical vascular grafting. It would be the most complex test yet of his skill and his center's resolve. The specter of loss was real, but so was the audacious promise of life. The surgery for Sophia Elms' retroperitoneal sarcoma was the culmination of everything Dr. Julian Vance and his center had achieved. It was the ultimate test of the Vance ethic, prioritizing life over liability and pushing the boundaries of surgical possibility. The complexity was breathtaking. It wasn't just a tumor removal, but a full vascular overhaul in the most vital area of the torso. The plan? Grafting the great vessels. Julian's plan required a 4-team approach, with shifts pre-scheduled for the anticipated 16-hour marathon. The core goal: excise the massive, grapefruit-sized tumor, which was entirely surrounding and adhering to the abdominal aorta and inferior vena cava (IVC), and replace the damaged segments of both vessels simultaneously with synthetic grafts. "We will use full visceral perfusion control," Julian briefed his team, standing before the large, detailed scans of Sophia. "We cannulate the femorals for partial bypass to secure the IVC. For the aorta, we will need to re-implement the segmental technique, but this time the clamp time is a matter of life and death for the kidneys and the gut." The crucial difference this time was the need to harvest and then re-implant the arteries feeding the kidneys, renal arteries, and the bowel, superior mesenteric artery, into the new aortic graft. This required meticulous, rapid work to prevent irreversible ischemia, lack of blood flow, to vital organs. The surgical marathon. On the day of the surgery, the atmosphere was one of quiet, absolute focus. Julian stood over the patient, his hands steady as they made the deep midline incision. The tumor was even more extensive than the scans suggested, a terrifying, vascularized mass that had choked off the space around the vessels. Phase 1. Tumor isolation, hours 1 to 4. The first 4 hours were spent meticulously dissecting the periphery of the tumor, carefully peeling it away from the abdominal wall and surrounding tissues. Julian worked with a neurosurgical precision, using micro-tools and magnification to ensure no surrounding structure was damaged. Phase 2. Vascular excision, hours 5 to 8. This was the crisis point. Julian clamped the aorta both above and below the tumor. The seconds began to tick, a relentless metronome counting down the viability of Sophia's kidneys and gut. Clamp time started. T=0, announced Dr. Hayes, now serving as the dedicated timer and first assistant. Julian worked with a speed born of years of practice and the recent experience with Ethan Miller. He quickly isolated and severed the renal arteries, placing thin tubes into them to pump a special cold preservation solution into the kidneys, buying precious minutes. Then, with daring swiftness, he carefully cut and lifted the massive tumor. It came free, a horrific, bloody relic of disease. The space left behind was vast, revealing the major vessels, the aorta and IVC, stripped bare and largely excised. Phase 3, the rebuilding, hours 9 to 14. This was the architectural phase. Working in tandem with Dr. Choi, the expert vascular surgeon, Julian began the graft placements. The IVC graft went in first, connecting the main venous return, allowing them to restore some partial circulation. Then came the aorta. Using a Dacron tube, Julian connected the main graft. He worked fast, his hands a blur, creating a clean, tight anastomosis. The most critical step was connecting the renal arteries and the superior mesenteric artery into the new graft, miniature vascular plumbing that had to be perfect to ensure long-term organ survival. Julian finished the last stitch of the final renal artery connection. T=14 hours, Dr. Hayes announced. "Release the aortic clamp," Julian commanded, his voice strained but strong. The graft flushed immediately. Blood rushed into the new highway and, importantly, into the major arteries feeding the kidneys and gut. The team monitored the organs. "Bowel Doppler signal strong," the scrub nurse reported. "Kidneys pinking up. No signs of widespread ischemia." A collective breath of relief swept through the OR. They had cleared the hurdle. The major organs were saved. Phase 4, closure and triumph, hours 15 to 16. The remaining 2 hours were spent ensuring hemostasis and closing the vast incision. At the 16-hour mark, the final stitch was placed. Julian peeled off his gloves, his body swaying with fatigue. He looked at Sophia Elms, pale but stable, her life now secured by a complex network of plastic and human tissue. He had performed the impossible yet again. He emerged from the OR and, instead of the administrative scrutiny he'd faced after Ethan Miller, he was met with a different sight. The entire Vance Center team, including doctors, nurses and residents, was lined up, exhausted but beaming. Dr. Harrison, Dr. Quinn, and even the skeptical Mr. Sloan were there. Dr. Sharma stepped forward. "Dr. Vance," she said, her voice thick with emotion, "you have rewritten the rules of medicine. Again. The tumor is out. The vessels are perfect. We have received confirmation from the NIH that they are now formally codifying your approach as the Vance Humanitarian Protocol. Julian simply looked at the assembly, then down the hall toward the recovery area where Sophia was being taken. He wasn't thinking of grants or protocols. He was thinking of a music teacher getting back to her students. He spoke, his voice quiet, embodying the core of his journey. This isn't about me. It's about what happens when you decide that a life is worth the risk. It's about the fact that no human being should be deemed inoperable just because the path is difficult. We took the chance they deserved. Julian Vance, the 30-year-old black doctor who graduated with top honors and dared to challenge the limits of medical possibility, had not just made medical history. Through his courage and his profound dedication to the marginalized patient, he had redefined the very meaning of humanitarian surgery. His scalpel didn't just mend arteries, it mended the broken promise of hope, one impossible patient at a time. The center was open, and the world was now watching the courage of his convictions unfold. Dear viewer, if you've watched up to this point, thank you for your support. I have a small request. If you enjoy my stories, you can subscribe to the channel, and don't hesitate to share your thoughts about the stories in the comments. Enjoy watching. Thank you for listening. Don't forget to subscribe to the channel and like the video.